Hello, so my name is Melanie Dalby. I am a pharmacist by background, but currently I am the Macmillan Patient Experience and Engagement Lead for Barts Health. I'm here to present cancer patient experience of virtual clinics. So before I get started, just want to highlight that there are quite a large amount of definitions for virtual clinics, but it can be described as the remote interaction between a patient and a healthcare provider using technology. In the literature, words such as telemedicine, and then when you combine that with oncology, tele-oncology seems to be quite popular. But for the purposes of what I'm talking about and for the study that I've done, when I mention virtual clinics, I basically just mean a telephone or a video conversation between a healthcare professional and patient. So there are a large number of benefits to virtual clinics. It is important to highlight as well that virtual clinics are not a new thing particularly, and virtual clinics have been used nationally and internationally in a variety of different disciplines for a very long time. But I suppose they've come to light a bit more recently because of the pandemic has I suppose forced a lot of healthcare organisations to move more to virtual clinics. So some of the benefits include the fact that patients hopefully don't have to wait as long for their virtual clinic, and they don't have to wait in a waiting room. Waiting rooms can be quite uncomfortable for some patients, particularly if the chairs are not designed for them. They can be hot and stuffy or cold. They might not have tea and coffee available, and patients can wait for up to some time before their appointment. Also travel. Obviously, if you're having a virtual clinic, it means you don't have to travel to get to wherever your clinic is. So you're avoiding public transport potentially, or utilising your car. And sometimes the journey itself can be quite stressful for some patients. So if you're stuck in traffic or your train is delayed, that can obviously be quite stressful because you're worried and you want to turn up to your appointment on time. With cost, potentially there is, if you're not having to travel, you're potentially saving money as well. So that is obviously an important benefit for our patients. Another benefit is perhaps if patients are particularly feeling unwell, the last thing that you really want to do is trek up to London, get on a bus. If you're feeling unwell, you more or less, you just want to stay at home and in bed. And it means patients can stay at home and still speak to their clinician. And obviously within your home environment, you can speak to your clinician on the sofa, sitting next to your cat, and hopefully be in a calmer, more sort of controlled environment that you're used to, which should help with your any questions you might have, and help with you feeling relaxed during your consultation. So there is information in the literature with regards to reducing carbon footprint. So obviously if you're not travelling, that does help to reduce the carbon footprint. And there is quite an interesting article about that. So I have included that as a benefit. So within Barts Health, we had been using virtual clinics or telephone clinics for some time. But like a lot of healthcare organisations, we realised that as the pandemic progressed, we couldn't be bringing in our patients, particularly our cancer patients who are at increased risk of infection. We couldn't really be bringing them into our hospitals. So we implemented utilised virtual clinics more than we were perhaps used to. And then during around the summertime, so June, July time, we wanted to evaluate the experience that patients have had during these virtual clinics. So two aims really. So the first aim was to determine patient experience of virtual clinic consultations themselves. And then the second one was to determine whether from a patient's point of view, these virtual clinics should be maintained on a long-term basis. At this point, summer 2020, we weren't really sure what was happening with the pandemic. Obviously, we know a lot more now. But regardless of the pandemic, it would be useful to evaluate virtual clinics because it might be something that we would want to continue with anyway. So in terms of our methods, we pulled a list of cancer patients from the electronic patient record. Patients were then selected from the list with regards to whether they'd had a virtual clinic since the 23rd of March. So staff working within the Macmillan Centre across the trust were utilised to call patients. So we've got 4 Macmillan Centres across our trust, so we've got quite a few staff in them who were able to call up patients. So they interviewed patients between 23rd of June and the 17th of July 2020. We used only 8 questions, but they were a mix of open and closed questions. And it's important to note that staff did not record these conversations, and the data was not transcribed verbatim. Staff made notes during the interview itself and then after the interview, which they recorded on an Excel spreadsheet, and then I was able to collate all of the information together to analyse the quantitative data and then pull out themes from the qualitative data itself. So these are our patient demographics. It's very important to look at patient demographics, particularly for our population. So Barts Health is a big teaching hospital across North East London, and we do have a very diverse population. So it's important when doing studies like this that the sample population that we use represents our true population. And I think we have achieved that. So we've got quite a good range of ages, a good split between male and female. And then in terms of ethnicity, we did interview quite a lot of white British, but as you can see, we did have a good variety of different ethnicity of patients that we interviewed. In terms of cancer type, so again, good spread. We did interview quite a lot of breast patients, but we do have quite a lot of breast cancer patients that attend our hospitals. As you can see, there is quite a good range of different patients with different cancers, and also some rarer cancers in there too. So looking at results, in terms of sample sizing, we didn't use any sort of calculation to work out an appropriate sample size. We were more thinking about how many staff do we have that are going to take part in these interviews, and how much time do we have, how much resourcing we have. And we sort of thought around about 60 patients would be suitable. We did highlight 68 patients that we thought would be good to interview, and we were successful in interviewing 55 of them. So 4 patients, actually, when we had looked at their notes, we realised they had not had a virtual clinic, so therefore it was not appropriate to interview them. 5, we were actually unable to contact them. 3, it was just not appropriate. So for example, one of them was very much approaching end of life care, so again, really not appropriate to call them up. And then for 1 patient, the data was missing, and their telephone number was not recorded on our system, unfortunately. So these are the results of the quantitative data. So of the 55 patients that we interviewed, all of them had had a phone interview. None of them have had a video interview. And I think at this point in the summer, a number of our teams were using video for their consultation, but it was sort of done a bit ad hoc per team preference, really. And it was still very much in the rollout phase. So this is something that we will hopefully reevaluate patients who have had a video interview. So we asked about the purpose of the consultation. As you can see, the majority are follow-up consultations. No patients had bad news delivered via consultation. And I suppose there is a bit of controversy around this, because some clinicians may prefer to give bad news, and some patients may prefer this if they're at home, because they're in their home environment, they're surrounded by friends and family. However, some clinicians believe that patients would prefer to be seen in person when delivering bad news. So that's still something that needs investigating. We asked patients who the call was with. As you can see, the majority of calls were with doctors, a few with nurse, and a few had a consultation with both a nurse and a doctor. So we asked patients to rate their experience of their consultation out of 5, with 5 being the best and 1 being the worst. As you can see, we did score quite highly, with the majority of our patients scoring 5 out of 5. And then importantly, we asked patients about the continuation of virtual clinics and whether they were happy to continue with virtual clinics or not. Majority said yes, they would be happy to continue with virtual clinics. Quite a few said no, some were unsure, and as you can see, some actually suggested alternating between face-to-face and virtual clinic, which was a very good idea. So in terms of qualitative data, the data was drawn out into 6 main themes with 2 sub-themes. So the main themes were a feeling of being rushed, face-to-face, difficult to assess, communication, which was broken down into the sub-themes of positive communication and barriers to communication, then benefits and compassionate care. I've given some examples of these. So remember that these are not verbatim, but just the notes that the Macmillan staff had written from speaking to the patients. So in terms of feeling rushed, there were actually only 3 patients that recorded this, but I thought it was important because it could quite negatively impact a patient's experience. And as you can see from this patient, the call was rushed, and it meant that the patient actually tended to forget some important information because of this. So that's obviously not a great outcome for that patient. Face-to-face was a very common phrase that was used throughout all of the interviews. And this seemed to be a little bit personal preference, but some patients clearly did want to be seen. So this patient, for example, wanted a face-to-face contact as she felt that her condition required eyes to be seen. There were some patients who did feel quite anxious and therefore would have preferred that face-to-face interaction. So in terms of difficult to assess, so this patient in particular, she found it difficult to discuss her treatment side effects. So she was having problems with her hands and her feet, and she felt that she was not able to discuss these side effects very well over the phone. There were a couple of other patients who did feel the same with regards to side effects. There was a patient who found it difficult to discuss their pain management over the phone and would have preferred it in person. And then there was a patient who had just had breast surgery and was recovering and was concerned about the healing of their wound, and therefore she would have preferred to have been seen in person. In terms of communication, so we've got positive communication and barriers to communication. In terms of positive communication, so some patients felt it was very easy to discuss anything over the phone. It was just quite straightforward for them. Barriers, so this patient in particular, she found it difficult to discuss her treatment plan at length, and just found it quite difficult. Another point of communication is around language. So a number of our patients, English is not their first language, and there was one patient whose son translated the consultation for them, and she found this very difficult, and it was very difficult to get her point across around side effects that she was suffering from, and she didn't feel it was appropriate for her son to translate. Then on the flip side to that, a daughter translated for the patient, and actually the patient found that that was absolutely fine and the consultation was very good. So something else to be considering there. In terms of negative communication, there were a few occasions where the line wasn't quite clear, and that obviously affected the consultation. So the benefits that were listed and reported by patients were very much similar to the benefits that I explained at the beginning of my presentation. And this patient in particular said that they find it very stressful coming into the hospital. So therefore, being at home, it was much less stressful for them. Compassionate care. So a lot of the patients were very grateful to the staff that they spoke to. So I've included a quote here from about a doctor and also a nurse. So with regards to the doctor, the patient said that the doctor looked after the patient very well. The doctor was a good listener, and the patient felt like the doctor cared. In terms of the nurse was very supportive and attentive. and the phone calls helped to pick the patient up when she was not feeling so great. So that's really lovely there. So in terms of recommendations going forward, I think it's really important that we have a clear standardised criteria to determine which patients are suitable for virtual clinics and which patients are suitable for face-to-face clinics. This needs to be not only communicated clearly with the clinical team, but also with the admin team who are booking patients in. And if there's any concern about which is suitable for a patient, then the clinical team need to be contacted to confirm that. Patient should be given a choice. In terms of that, they need to be informed about the risks versus the benefit of whether or not it is appropriate to have a face-to-face or virtual clinic, but I think it needs to be a joint decision. We should utilise our CNSs more in consultations. CNSs have a number and a wide range of different skills, so increasing the involvement of CNSs would be very beneficial. And then, as a few of the patients said, consider alternating face-to-face consultations with virtual clinics. This kind of offers the best of both worlds, I suppose, and is dependent on the pandemic, but it's something to look at. And then, as mentioned, allowing for translators to be available. If, for example, a family member is happy to translate and the patient is happy with that, then fine. But I think having that opportunity provided to say, do you need a translator for your appointment, then it means that one can be provided. And then making sure the patient has enough time during their consultation. So making sure they've got enough time to pause, think things through, take their time to make decisions, not rushed at all, and then any time for any questions that they may have. And then ensuring that the right tests are available. So there were a couple of examples where a patient's PSA test was not available prior to the clinic, and the patient didn't really see the point of the clinic then without having their PSA result. So it's making sure that the right test is available, and if it's not available, then perhaps delaying that appointment until the results are back. And then re-evaluating and including clinics using Attend Anywhere. So Attend Anywhere allows for video functionality. And I'm working with an M.Pharm Year 4 student at the moment who is doing a re-evaluation of this work as part of her dissertation. So she is going to interview less patients than what we have interviewed, but she's going to do much more in-depth analysis. So in-depth interviews, recording the conversation and transcribing it verbatim to use thematic analysis to analyse the data. And as part of that, she's also going to speak to and interview clinicians, because it's important that we understand the experience of cancer patients in terms of virtual clinics, but also of the clinicians that use them, because we want to make sure that we're making improvements for both parties who are involved. And just want to say that this work has been published in the Journal of Oncology Pharmacy Practice. So if anybody wants more information on this study, read the article. We will be publishing the results of the re-evaluation that's currently ongoing. Let's see, if anyone wants to contact me, my email is just there at the bottom of the screen. And lastly, if anyone has any questions, then feel free. Thank you very much.